Welcome to this spotlight on GLP-1 receptor agonists. We're delighted that you've joined us for this dynamic and wide-ranging dialogue on the use of GLP-1s in the individualization of treatment of type 2 diabetes. Now, we will present this information in a late-night talk show format, although I apologize that we will not have a snazzy live band or singing artists, but we have some dynamic guest experts in the form of Dr. Jens Juul Holtz from Copenhagen and Davida Kruger from the Henry Ford Health System in Detroit, who will join me, Dr. James Gavin, as your moderator, and we will explore what developments have propelled the GLP-1s to the top of the pecking order as preferred therapy for type 2 diabetes. But we're going to start by looking at what factors have led to the elevation of the GLP-1s for treatment in the algorithms. And if you go to the ADA guidelines, you'll see that these agents are recommended for patients at high risk for ASCVD or patients at high risk for CV events even after they've started metformin. And they're recommended independent of what the baseline A1C is. They are recommended for patients with diabetic kidney disease and albuminuria if SGLT2 inhibitors are not tolerated. That's a very important advantage because these agents are very important for managing CKD because people with CKD are at high risk for cardiovascular events in the presence of type 2 diabetes. And if there is a compelling need to avoid weight gain or hypoglycemia, this is a set of benefits beyond glycemic control. But we start with glycemic control because this is still the foundation of how we treat type 2 diabetes. Remember, all of the drugs are approved on the basis of their ability, first and foremost, to lower glucose. If you look at drug-naive patients, at the changes in A1C when they're treated with different agents, 4 of the top 5 drugs are GLP-1s. If you look at the changes in A1C after drugs are added to metformin, 3 of the top 5 are GLP-1s. These are robust agents in their glycemic effects. But beyond glycemic control, these agents have shown powerful benefits in the reduction of cardiovascular outcomes. These CVOTs that are summarized here show the effects on 3-point MACE. And remember, these are the kinds of events that are the leading causes of morbidity and death in people with diabetes. The trials that have been done have shown statistical significance for LEADER, REWIND, and SUSTAIN. Pioneer was too small. It was not powered as a superiority trial. These are very important studies because all of them show neutrality, but benefit was actually demonstrated with the 3 that you see here. And what we know with subgroup analyses is that none of the subgroup characteristics that are shown in this panel account for the beneficial effects that we're seeing. It was not an outcome that was driven by effects of pre-existing BMI or established CVD or dosing frequency. That's what these interaction values tell us, that the only thing that was closely related, almost significant in terms of the effects on these outcomes, was the degree to which these agents were homologous to native GLP-1. So what we see is that now these robust data have led to some approved indications. All of them, of course, are diabetes drugs approved for glucose lowering as an adjunct to diet and exercise. But the important additional benefit is their beneficial effects on MACE. Dulaglutide, liraglutide, and semaglutide are all approved to reduce MACE in patients with type 2 and established CVD. In addition, dulaglutide has achieved an indication for primary prevention. And then to date, the only agent that has been approved for the pediatric age group, or those patients 10 years of age or older, is liraglutide. Now, an important additional set of benefits is the degree to which these agents avoid hypoglycemia. What the outcomes trials have shown is that there was no statistical significant increased risk of hypoglycemia unless these agents are used in conjunction with the sulfonylurea or insulin. And how do you mitigate that risk? You mitigate that by reducing the dose of the sulfonylurea or insulin when starting the GLP-1. This minimizes the risk of hypoglycemia. And then, of course, because so many of our patients with type 2 diabetes or overweight or obese, the weight effects are extremely important. What you see here are the changes in weight with GLP-1 treatment from this meta-analysis of a lot of different trials that have compared the GLP-1s with various agents, and there's always this beneficial effect. There is a reduction in weight, more compared to some agents than with others. But what you see in the box that's highlighted on the right is that there is this trend towards impressive weight reduction using GLP-1s. It's not the same for all of them. There's less weight reduction with dulaglutide, although still some, but the most weight reduction that we see is with semaglutide that you see on the far right. So what all of these data point to is that when you look at the high glycemic efficacy, robust glucose lowering, when you look at the statistically significant benefits on CV risk reduction, secondary prevention, as well as now primary prevention, we see, in addition to that, low risk for hypoglycemia. When you add that to the beneficial effects on weight reduction, this is why the GLP-1s have reached the top of the pecking order for treating type 2 diabetes. So what we're going to do now is take a break, and then when we come back, I'm going to introduce you to the first of our fantastic expert guests. I'm delighted to welcome our first expert panelist in the form of Professor Jens Juul-Holtz from Copenhagen. And it's a special treat for us because between myself, as a past president of medicine and science at the American Diabetes Association, and Davida as a past president of health and education at the American Diabetes Association, Jens is this year's recipient of the Banting Medal for Scientific Achievement, and we are extremely proud of that, and we want to say congratulations on that distinguished achievement, Jens.
Thank you very much. Thank you very much.
So the first thing I want to do is to share with you some survey results that we got to the question of how often do you recommend GLP-1 receptor agonists to patients with type 2 diabetes, primarily to reduce their cardiovascular risks. And we were very interested to see that the vast majority of respondents either sometimes and almost half of them frequently or always used GLP-1s for this particular indication. So Jens, let me pose the question to you. What is your view? What are your thoughts on why we saw statistically significant reductions in MACE with those GLP-1s that were sort of human-based GLP-1-based agents opposed to the Exendin-based agents?
So I think that's a very good question. The general thinking is that we have a class of agents here, the GLP-1 receptor agonists, and once that you have activated that receptor, in principle you should do the same with all the different agents. So, but there are differences, and first of all, we have differences in the molecule. Some are based on the Exendin 4 backbone. The others, all of them, are based on the human GLP-1 sequence, and that could make a difference. I'm not saying that this is proven beyond doubt because it seems that they do activate the receptor in a very similar way, so I don't think that's the main reason. So let's think of something else. So exenatide, which is given twice daily, has an exposure which is much shorter than any of the other agents. It is down to just actually a couple of hours, and the same is true for lixisenatide. And so the most likely explanation for this is the lower exposure rate during the 24 hours of the day. That is absolutely the most likely explanation. Now, the long-acting exendin should be much better in this respect. And actually, there was a very strong tendency in the cardiovascular outcome trials for exendin in this relationship to be significant. It was very, very close. So most people feel that this was just bad luck in a way, that it didn't make it to significance. And I have a small comment to add to that. That is that I think the dose of the long-acting exendin is a little bit too low, and that also fits with the fact that the general side effects profiles is also a little bit on the low side. So this really has historical reasons. It was introduced in this dose of 2 milligrams, and nobody has really had the energy, time, and money to make the studies required to increase the dose. So I think this is also a dose question. So we have these differences in pharmacokinetics, and I think that is the most important difference we have, and then the dose question. Yeah.
So we're still learning in many ways what the actual capabilities are as we sort of test new doses, test different populations. Interestingly, the exendin results may have also suffered from having a pragmatic clinical trial design, which was not exactly ideal for such a study. Let me also ask you, beyond the glycemic benefits, have there been other benefits that have really caused these agents to rise to the top of the pecking order? I alluded to this earlier, that it's beyond glycemia that these drugs have really presented themselves as beneficial.
Yeah. So I've really been very interested in this question for a long time now, and I've been very interested in this surprising, actually, it was surprising, effect on the cardiovascular system of the GLP-1 receptor agonist. Nobody had really expected this, and with the LEADER trial, that when it came out significance in terms of MACE reduction, it was a little bit of a surprise, I must say, at least to me. But there are a number of explanations why you could think about this. So one discussion we must have, of course, is whether it's actually the lowering of A1C that is driving this. And strong support for this is really to be found in a mediation analysis of exactly liraglutide, of the LEADER trial that has been made and published. And it highlights A1C reductions as by far the most likely of all the parameters that were investigated to explain this. So the other question that one must take up is there a direct effect on the cardiovascular system? Is there an effect on the heart? Are there effects on the vasculature, on the endothelial cells? And one of the problems has been that it's been very difficult to find receptors for GLP-1 with certainty in these structures. And nobody really understands what the mechanism is of the heart. The mechanism on the heart is to increase heart rate, and that is by everybody suggested to be a bad thing. So, I mean, you would impair the risk of the patients here. So it must be something else. And I can point to the lowering of blood pressure as perhaps one important parameter here. That's pretty significant. And the one of all the agonists that has the strongest decrease in blood pressure is also the one that had the strongest reducing effect on MACE. That was semaglutide in that study in the SUSTAIN 6 trial. So that could be one thing. Another very important thing, I think, is the frequency of hypoglycemia, because it is proven beyond doubt that the use of GLP-1 receptor agonists for diabetes therapy causes less hypoglycemia than in the controlled, in the placebo-controlled control groups that have been looked at. So, and I don't think that anybody would deny the beneficial thing of having fewer hypoglycemias during a therapy. So I think that is also important. But of course, and then there is inflammation also. So is it true that the GLP-1s have anti-inflammatory actions? And I've seen some results now, several sets of results, showing very significant reductions in CRP levels. So it seems that there is seriously some effects on inflammation also. So, and then building it all together, I think perhaps that at least there's a hope that the GLP-1 receptor agonists slow down the progression of atherosclerosis, and that this is really the mechanism by which they're working. And those are my personal thoughts about this until we get wiser and understand better the exact mechanisms of actions of GLP-1 agonists on the cardiovascular system, because that's still lacking.
And it doesn't stop there, it seems. Beyond the effects on the cardiovascular system, diabetes is such a complex disease with multi-organ involvement, which is why we hear cardio-renal, cardiometabolic effects. The renal effects are also increasingly becoming important and have, in fact, been looked at quite deeply.
Yes, and you're completely right. I think this is also very important that in all of the cardiovascular outcome trials, even in the DPP-4 inhibitor studies, there has been actually significant effects on renal or renal protective effects, if you will. And I think this is very, very interesting. But if we have difficulties in understanding the effects of the GLP-1 agonists on the cardiovascular system, our understanding of the renal systems is even worse. Again, we have a problem in identifying the exact location of the receptors. We know, and this is beyond doubt, that there is reception on the afferent arterioles, and they're very likely to relax the afferent arteriole, and that should mean that they would have significant effects on renal blood flow, on glomerular perfusion. But that has been very, very difficult to prove in all the studies that I know of in humans. You can show that very nicely in rodents, where you can, do all the things you can't do to humans. But in the clinical trials where this has been looked at, precisely the glomerular flow has not been changed. The only thing that and then there's been a long story about the proximal tubules where people think that there might be a receptor, but that is again a very controversial thing, and I haven't seen any convincing data, really convincing data, that there is a mechanism for GLP-1 on the proximal tubules. What we have found ourselves is that there may be an action on angiotensin II, and that I think is perhaps a promising way ahead to understand the renal effects. But the effects of GLP-1 agonists on the kidney and on the renal protective effects, they are beyond doubt. There's very clear and significant effects in all of the trials. Perhaps it's mainly in reduction of albumin excretion rates, but that is a good thing, of course. Whereas the effects on maintaining glomerular filtration rates are slightly less impressive, at least less impressive than those of the SGLT2 inhibitors. But I think this is the status of it right now.
Well, it's been a good finding that the protection of the kidney has been impressive. That is, they've all been safe. They've had beneficial effects even in the face of albuminuria. And this is important because we can use GLP-1s under circumstances where there may be limitations with the SGLT2 inhibitors. Yes. And the two actually have complementary mechanisms where those actions may be needed.
Yeah, I've actually personally been involved in a large number of studies in patients with diabetic kidney disease and other kidney diseases, and you're right. It is possible to use the GLP-1 receptor agonists in all stages of renal disease, even in people on dialysis. You can use it and still use it safely. They're a little bit more vulnerable to the nausea effect of the GLP-1 receptor, so you have to reduce the dose. It's not because of the pharmacokinetics, it's because of the side effect with nausea that you have to be a little bit careful. But still, they work very well. So you can use them actually over the entire spectrum of kidney function.
Jens, let's look at another thing that has happened in the evolution of these agents, and that is now we've gotten the appearance of different dose formulations. one of the exciting developments has been the availability of an oral GLP-1. And we did a survey. We actually asked respondents, how often do you recommend oral GLP-1s to patients with type 2 diabetes? Interestingly, a similar breakdown of responses to that question was received as was to the first one. Namely, over 90% used it sometimes to always. So we're seeing a pretty good uptake. So would you talk a little bit about the evolution of the dosage of and formulations of these GLP-1s?
Yeah, with pleasure. I have actually been, you know, closely standing by this process all the time. I've been working with it, and I remember I was asked by a company once to comment on the development of an oral GLP-1, and I called my lecture that I gave "Mission Impossible," but they didn't listen to, which was a good thing, of course, and they went on with the development. And it is really a formidable task to create an orally active GLP-1 agonist, because it is really from the entire physiology. It's not supposed to survive that route through the mouth and in the stomach and the small intestine. So it is really completely impossible. But you have to do something very, very special. And but there was a lot of work going on here, and I must say that it was fortuitous that something called SNAC was already available when people started thinking of GLP-1 agonists also. And actually, a very early study, more than 10 years ago, was done by Dr. Becklinger in Switzerland, where he did this. He formulated a GLP-1 with SNAC, and then he gave it to people, and they got nauseated and they vomited, and they had all the reactions. So it simply worked. But it was all over in very few minutes because, as you know, GLP-1 doesn't survive very well in the circulation. So this was not a way ahead. And many people had high hopes to oral administration because it was felt that this would be perhaps more similar to to the endogenous GLP-1, which also comes from the gut, right? So it could be a wonderful way of doing this. And then all that turned out was that it caused a lot of nausea. So the trick here is really to combine the oral administration with an extremely long-acting GLP-1 agonists. So of course there are two things to look for. Another thing, that is to get it absorbed at all. But here again, the SNAC technique was ready and available. So now it was a combination of the SNAC, which is coating the molecule in a way so that it gets absorbed in the stomach. That was found out later. Absorbed in the stomach, and then because it's so extremely long-acting, so whatever comes into the circulation that way has this very long half-life of a week and so. So this was the technique really. So just a little bit has to enter, and indeed with the oral semaglutide, most of it, 99% is lost, but this 1% is taken up, and it's even variable, but that doesn't really matter because it just enters the circulation and builds on top of what was there already because the substance is so long-acting. So these are the two essential features here. The combination with an absorption enhancer, and this is called SNAC, and the very long duration of action of the molecule. That's the secret.
And it seems as if the presence of that absorption enhancer does place some demands on the way we dose it. That is to say, you have to really take it on an empty stomach. You have to be
That's
fasting.
Right.
You have to do it with a small amount of 4 ounces of water, nothing else. Right. And you really can't take other medications or food with that in that 30-minute period that you have to wait before you add anything else, so that you don't disrupt that neutral pH that you generate with that SNAC. It's really a wonderful setup that allows the evolution
You're
of this.
absolutely right. That is very essential. It must be done like that, because what has to happen is that the tablet must adhere to the wall of the stomach. And once it's in this position, right that position, that's when the enhancer, the SNAC, makes it possible for the GLP-1 to diffuse quickly across the mucosa and into the circulation. And it's over in just a few minutes, really. So it's a wonderful technique. It works very well, but you must not disturb it with other nutrients, with nutrients or drinking. That's essential.
Thank you very much, Jens, for those wonderful comments. And we're going to turn our attention now to our second expert panelist, who is going to talk to us about what patients need to know about GLP-1. So this is going to be a more patient-focused segment, and I'm delighted to welcome Davida Kruger, who has been over the years one of my go-to people in the diabetes space. And I mentioned earlier, Davida is a past president of health and education in the American Diabetes Association, and a delightful colleague. And welcome, Davida. And I'm going to start by sharing some survey information with you, as I did with Jens. And we asked the question: when an injectable medication is needed for a patient with type 2 diabetes, what do you initiate first? And interestingly, over 70% of the respondents indicated that they used a GLP-1 as their first injectable, which was really quite encouraging in many ways. So I'm going to ask you, Davida, what is the strength of the evidence that makes the GLP-1s a more compelling choice for the first injectable therapy than basal insulin, which is what we've been doing historically for many, many years?
I am absolutely thrilled by the survey results, because that is exactly what we hope is going to happen, is that the first injectable should be a GLP-1. Why? Because when we look at the data, we can see that there's extraordinary A1C lowering. And while it's not marketed for weight loss, we also see weight reduction, and we don't increase the patient's risk of hypoglycemia. Now, of course, if they're on sulfonylurea or we add it to insulin, then those medications can cause some issues with hypoglycemia. But in general, these drugs are glucose dependent, which means when blood sugars are elevated, you see a benefit. When the blood sugars are normalized, they have a mechanism that they turn off so that they don't increase the risk of hypoglycemia. So when we think of the needs of people with diabetes, the two things that really are bothersome are hypoglycemia and weight gain. And if we choose a GLP-1, we minimize both of that by also providing a good A1C reduction. And we can provide it once a day, once a week. We can do it in orals, so that we have such a nice spectrum for patients to choose from. So those are the other reasons why it's so nice to be able to use a GLP-1 as the first therapy after metformin. It does provide great abundance of benefit to people with diabetes.
You mentioned the hypoglycemia issue, a reduction of that risk with these agents, and we actually asked in a survey question respondents the question: how often do you recommend GLP-1s to patients with type 2 diabetes, primarily to reduce their risk of hypoglycemia, as opposed to using an insulin as the first injection? And again, we were encouraged that over 50% did so frequently as a means of avoiding hypoglycemia. What do you find that encouraging as well, or surprising?
Not surprising, but very encouraging. So when we offer better diabetes control, new medications, whatever we're offering to people with diabetes, when we say insulin, the first thing the patient thinks about is, Aunt Sally, who had that awful hypoglycemic event in the middle of a store and passed out. Now, there are things we could have done perhaps to prevent that, because insulin is still a good therapy. But if I can say to the patient that right after metformin, which does not cause hypoglycemia, we're going to give you a second medication that does not cause hypoglycemia in of itself, people will buy into it, and also because it doesn't cause weight gain. So I think that's phenomenal. It's one of the things we love about GLP-1, and the fact that the patients can feel comfortable and confident, and so can family members, because they worry about that hypoglycemia as well.
So clearly there are important concerns about hypoglycemia on the part of the patient. But to the providers, it's also a concern, because one of the things that it implies is that if you're using an agent that's less likely to cause hypoglycemia, you do some different things in terms of the frequency of glucose monitoring that you recommend. How do you deal with that in terms of the approach that's taken to self-monitoring, the use of continuous glucose monitoring in patients who are using GLP-1s as opposed to an insulin injection?
Well, you know, over the years, one of the rate limiting factors to getting people to the treatment goals that we want them to be at has been hypoglycemia. We saw that back in the diabetes control and complications trial, you know, back in the 80s and 90s. And every time we try to lower the A1C, if we're using something that causes hypoglycemia, we can't necessarily get to the treatment goal that we want to. When we use a GLP-1 and we support it with something like, if we need blood glucose monitoring or continuous glucose monitoring, we see that the patient's not having hypoglycemia. So not only is the patient not having hypoglycemia, but they don't have to check before each meal and at bedtime after each meal, as if when we were using insulin to control before meals, after meals, and at bedtime, and sometime during the night. So while I personally think it's really important to have patients watching some glucose data to see what's happening, because it's hard to know where to go if you don't know where you've been, it's not as urgent or as frequent. And also, you know, in this era, we have self-monitoring of blood glucose, but we also have continuous glucose monitoring, so patients don't have to poke their finger. They can wear a device that allows us to see blood glucoses around the clock. So, you know, having a choice of medication that does not cause hypoglycemia, the urgency of blood glucose monitoring or CGM is not the same vein. It's different. We're using it to help the patient learn to just live with their diabetes. We're helping them with nutrition. We're helping them with physical activity. So it's a different urgency because we're not as concerned about hypoglycemia.
Now, along the same lines, in terms of non-glycemia related issues and benefits with the GLP-1s, we asked the other question to respondents, namely, how often do you recommend GLP-1s with type 2, primarily for their effects on weight? Now, sometimes people who are not concerned so much about hypoglycemia, they will be concerned about weight. Interestingly, the surveys, whereas about 50% of people in our respondents were concerned about hypoglycemia and used GLP-1s as a recommendation, over 60% used GLP-1s because of their concerns about weight. How important are the effects on weight to patients versus providers, and how does this affect treatment choices that you make?
You know, so I had a young woman come into the clinic last week. She had been on insulin now for 6 weeks. She had gained 12 pounds. She was not happy with me. And what happens is when you lower the A1C, everything becomes more effective. The patients aren't peeing out their glucose, and as the A1C comes down on insulin, the weight will go up. That's just what we know. And then I had another patient who was treating hypoglycemia, and she gained weight from the calorie choices of treating hypoglycemia. So if I can say to the patient, there's weight reduction associated with the use of a GLP-1, I can tell you nobody will give me pushback in taking an injection for no hypoglycemia and no weight gain, and especially no weight gain. I'm barely 5 feet tall. If you told me I was going to put on 10 pounds from the medicine, I'm pretty smart, but I might say, yeah, not so smart. I'm not going to do that. So it's huge benefit to having weight reduction instead of weight gain. And we know the data, the A1C lowering is phenomenal, as well as the weight reduction, which does not happen with other medications.
And there are really compelling data sets on the one hand regarding the avoidance of hypoglycemia, but on the other hand, the association of use of these agents with reduction in weight is really compelling across the spectrum of other agents that are used in type 2 diabetes.
And I would say to you that, for me, I will always pick the GLP-1 first. But if a patient comes into my practice, because I'm in an endo practice and someone else may have started them on insulin, I can still add to that insulin with a GLP-1 and still see the A1C lowering and still see the weight reduction. So we want to use it as a first-line therapy, but if we can't, we can certainly put it on in the back end as well.
So we're in an era where we get a lot of direct-to-consumer advertising, and there's a lot of word of mouth. How often do you actually have patients come in asking for treatment with a GLP-1? We asked in our survey data, and interestingly, about equal percentage of people said infrequently, sometimes, and frequently. So it was like all over the map.
Yeah.
What's been your experience?
I have patients who come in singing the jingles that are on the TV. And I've had patients come in with a box from a friend who's taking a GLP-1 and say, I want this drug. So I think we're very proactive in offering GLP-1, but we have patients that come in on a regular basis or call and say, I just saw this on TV, explain to me what it is and what it isn't, and do I qualify to take it? And I think that's marvelous. I think that diabetes is a team approach, and if patients are coming in and asking for it, the adherence goes up tenfold by the fact that they're engaged at that level.
So this team approach that we have to have with diabetes really now makes it so important that we do appropriate navigation with patients, because they do have to be in the driver's seat. So they have to know what to expect with respect to the side effects. They have to know about timing, and they have to know about how it's going to affect aspects of their life. How do you make sure that they know all of the things that they need to know? And what are you learning from your patients in terms of those who do go on GLP-1s? What are you learning about how it affects their quality of life, their perceptions of this?
Well, first of all, I think it's really important that there be no surprises, because we all lose if you don't really say, this is how the drug works. This is the potential side effects. We talk about nausea. We talk about GI side effects. We talk about satiety. And while you and I might not think of that as a side effect, and we think of that as being very positive, when people have to change their food intake and it affects how they sit at the dinner table for family dinners, and they're not eating the same amount of foods as they ate in the past, those are all things that we have to talk about and work through with our patients. I think actually taking the injection is very simple, and we like patients to take it in front of us, whether it be in the office or on a video visit, but we want to take the first injection with our patients. But we talk to them about the fact that, until they got a GLP-1, the food didn't stay in their stomach long enough. They had rapid gastric emptying, and now we're going to normalize that. And so they were hungry, and now they may not be hungry. And if they continue to eat the larger portions that they may have been eating, they will get some nausea. We say, you're kind of filled up to here, and you're going to get nausea. So we talk to them about maybe taking half as much food on their plate as they're used to, chewing slower, stopping when you're full. You can always go back for more. For many of my patients who have not been successful with weight loss programs, it's a great time to reintroduce those weight loss programs, because now that they have satiety, they can be successful. So we talk about all the potential risk, benefits, side effects, and making sure that the patient knows what a GLP-1 is and what a GLP-1 isn't. We also talk about the fact that there may be limitations in terms of weight reduction. This is what we have seen in research. That doesn't mean I don't have patients that have more or don't have less, but we want patients to be very realistic. And then we talk about titration. It's really important to follow the titration provided by the company, each of the companies. And so even if they've been on other GLP-1s, I start them over. If they're going from a once daily to a once weekly, I start them over, because I don't want them to have nausea. I don't want them to have any problems. And if I slowly titrate, I have found that they have less issues with nausea as well. So following the indications provided by the pharmaceutical companies is very helpful in terms of dosing. And then I do try to get rid of other medications. Like if they're on a sulfonylurea, let's get rid of that. In my book, they cause hypoglycemia, they cause weight gain, they're kind of nasty if we can get rid of them. And then use a higher dose of the GLP-1. Take them to the maximum dose to get the maximum benefit from the GLP-1.
Now, one of the advantages that we have with the GLP-1s is that we have different timing of dosing possibilities. For example, we have once daily and once weekly options. You would think that most people might want the once weekly. Has that really won the day, or are we seeing a different pattern emerge?
You know, I would have thought once weekly everybody would be all over it. And I will tell you the majority of my patients love it. We set up a calendar, there's reminders they can get to take it once a week. And for most people, that's marvelous. But I have patients who say to me, you know what? I do everything else once a day. It kind of reminds me, I get up in the morning, I take that medication, and it sets me straight for the day. And so I want to stay with a once daily. And it really doesn't matter. Whatever the patient's doing, we find that the GLP-1s are really so enhancing to their lifestyle and all of the ingredients that it brings to the table. It doesn't matter to me whether they take it once a day or once a week. And we offer all so that it does fit into their lifestyle. And that seems to be working.
Let me pose the question to both of you. The GI effects clearly pose the biggest need for education and orientation for patients going on GLP-1s. What is it about these agents that cause these cause these GI effects? Are they transient? Is that what you teach? And is there anything that your experience or research that you've done to suggest how you might best mitigate them? Jens, you might want to weigh in on this as well.
Yeah, so it's true that we have these side effects, and it's always been puzzling, and people have really been discussing why that was. I'm pretty sure that the nausea, if you take that, is a central effect. It's elicited via the central nervous system, and it's probably mediated by receptors which are sitting in what is called the area postrema. So that's going to be difficult to do something about, because that's a natural mechanism. But the important thing is how to avoid them is by doing a very slow up titration. And I completely support what Mrs. Kruger said about the dosing and how to dose it. And actually, the more slowly you can do it, the better it is. And we know that, interestingly, from the combination with GLP-1 and insulin in a fixed combination where the up titration is governed by the insulin. And that is very, very slow, as you know. And that forces the up titration of the GLP-1 component also to be very slow. And in those studies, there were hardly any of these GI side effects. So they're not so GI as people usually say. Why are they transient? And that is really difficult to say. There is an adaptation going on, and we don't really know what that is. Many people think that the main effect is this effect on the gastric emptying. But for the long-acting GLP-1s, there isn't really a lot of effect on the gastric emptying rate. It's true that the GLP-1s, they will relax the entire GI tract, and that probably is the explanation for some of the diarrhea that occurs. That's the relaxation directly on the receptors in the GI tract. I think that is the most likely explanation. But the actual gastric emptying rate may be slightly affected, but in the chronic therapy, it really shouldn't make a huge difference. Acutely and with the short-acting GLP-1s, you have a tremendous effect on gastric emptying rate. And but already after some 4 hours, the desensitization sets in. And after 24 hours, you have a completely full desensitization of this effect. And why that is, I'm sorry, I don't know.
Well, you know, at the end of the day, Davida, despite what we know or don't know about the science that's involved, what we really want to be sure of is that patients will stay on therapy, because these are excellent drugs and we want them to stay on them. What do you find are the most sort of patient-friendly kinds of advice that you can give that make people say, you know, that really helped me a lot, and they therefore adhere better?
I really do think the slow uptake titration is humongous. We can't underestimate that. There's no rush to the finish line, and that's what I tell my patients all the time, that yes, your A1C is not where we want it, but we want to be sure that we don't cause more nausea. And so I will go low, and I will go slow, and I will go for a longer period of time. I do counsel them on higher fat foods and some different nutritional intakes that may be helpful. And the other thing is that rather than stop the medication, call me. Let's work this through so that we can be sure that you still get to stay on the medication and you benefit by it. I will tell you that I can probably count on one hand, oh, maybe two hands, the number of people who've called and said, oh my God, I can't stand the nausea or I can't tolerate this. Most of them will say, I can get through this and it is transient and I'm seeing so many other benefits. And I think we have to constantly say, well, what about your blood sugars? How do they look? What's happening with your weight? And I think by saying that, when they see the big picture, the whole picture, that they feel better about getting through if they in fact have nausea.
Yeah, that's really very insightful. And one of the things that I've found helpful is that I've asked patients to actually jot down what they've done in the period around having significant GI distress. What meal did they just finish? What did they have in that meal? So that they can start gathering a record for themselves of what kinds of things might prompt one of these kinds of adverse events. Therefore, they know what to avoid based on their own experiences, and it has proven to be quite helpful. And this whole business of shared decision making is so important when you get the right partnership between patients and providers in terms of what the best fit is. That's what we're doing with individualization in a way that it's going to be something that they will stick with, because no matter how good the medicine is, if they don't stick with it, it's just not going to work. I want to turn our attention to another matter that's important in the guidelines, because the guidelines have evolved in a way that put a few more demands on us as providers, because now as we make assessments of patients when they show up, we are now being asked to be more intentional about what is this patient's underlying status with respect to ASCVD. And that's not something that was always top of mind in symptom-free patients, for example. But now the guidelines say if you're going to make the right choice of agents based on all this good data, you need to know. And the question becomes, what should we be doing? How do we best go about assuring that we are making this kind of assessment? So as we move to this last segment on incorporating GLP-1 receptor agonists into individualized treatment plans, this might be something that is best done from the standpoint of looking at case studies. And I want to invite our panelists to sort of weigh in on just a few illustrative cases. These are not meant to be ideal, but to raise some important questions. Are we ready to go to that?
I think so, and I also think that, you know, I find it really interesting that, you know, we have to be so exacting about the fact that we want to be sure the person has cardiovascular risk. But I would say to you, Jim, is that they have diabetes. Most of them have hypertension. Most of them have family history. So, you know, I wonder if we're being over the top. That's my personal opinion. And why would we not just protect them from cardiovascular disease? But I know that the ADA wants more.
Yeah, this is a good issue to discuss, because when you consider what the downside is compared to the upside in terms of making choices like these, the upsides win by a lot. But let's save that for a minute. Let's go to a case, and I want to introduce Jeffrey. Jeffrey is a 54-year-old senior business manager. He's a guy who has a pretty high-stress job, somewhat sedentary. He has type 2 diabetes for 11 years. He's also had hypertension for 12 years, not unusual. But he has a family history of CVD. In fact, his dad died at age 59 with an MI. Now, because of concerns, he went and got a calcium score. And it turned out the score was 140, which meant that he was at moderate risk, as we wouldn't be surprised. His A1C started out at 9.3. They put him on an SGLT2 inhibitor about 15 months or so ago, and it fell. He had a response, nice response, came down to about 8.2, 8.3, and he had some initial weight loss. But given everything else, he's seen his weight start creeping back up, which is, again, not unusual. And his PCP has told him, you should assume that you have some underlying cardiovascular disease. So what do we do now? He needs control, and he is not optimized where he is. So what do you want to advise a patient like Jeffrey to do right now in terms of intensification?
Well, I would say, though, that if we're looking at his risk factors, he has diabetes, hypertension, male sex, his age, and family history is 5 of the 6 things we look at when we're looking at risk factors for cardiovascular disease or having events in the next 10 years. So this guy would need a medication that could protect him, and I think he's a prime candidate for a GLP-1.
And I would agree completely to that.
Now, there are many reasons based on all the things we've talked about why this guy would be a good candidate, but it raises the question, in general, is there a preferred time, a best time, for introduction of a GLP-1 in a patient like Jeffrey?
I think that boat sailed. I think we should have done it sooner.
So you would have started him earlier, Jens?
I would also. And this is completely in line with what I said about the possibility that the GLP-1s are, that they are slowing down atherosclerotic progression, that they are kind of protective, that they are kind of preventive in their mode of action, as opposed to the SGLT2 inhibitors, which are fantastic drugs actually on cardiovascular events, but act acutely in a completely different mechanism of action. So yes, absolutely, as soon as possible, I would say you should enter with the GLP-1 receptor agonist.
And it's a clinical judgment issue, but I think we have to sort of get into the rhythm of looking at the total patient in terms of all of the things that we're trying to have effects on, including many of the underlying mechanisms of what's driving the adverse effects in those patients that will help us make a definitive choice. What do you tell them about what to expect once they start on a GLP-1? In terms of benefits, I mean, they always want to know, what is it going to do for me?
Well, we're hoping this gentleman is also on a statin. His blood pressure is well controlled. He's not a smoker, that someone's advised him about weight reduction. But, you know, some of the things that they're going to benefit by, they're not going to be able to see. But I do talk to my patients about the CVOT trials that, you know, we all did those because they were asked of us by the FDA. We never expected to make history. And we did make history. We made history for people with diabetes. And so hopefully, if I get this man on a GLP-1 receptor agonist, not only is it going to improve his diabetes, but hopefully it's going to decrease his risk of cardiovascular disease in the long term. And I do share that with them.
Yeah, and I support that completely. Again, it's the kind of preventive aspect of this that is so extremely important. There's a reasonable hope that you can prevent some of these events from happening when you're on a GLP-1 receptor agonist, and that to me is very important.
Now, in his case, in Jeffrey's case, they put him on an SGLT2 inhibitor. Not a bad choice. It just turns out that it wasn't exactly optimal for all the things that he needed for the length of time that he needed them. Many patients like that would have been put on a DPP-4 inhibitor. And the question becomes, what is the current state, Jens, of people actually using both DPP-4s and GLP-1s? Because unfortunately, we still find that happening from time to time.
So for a number of the GLP-1 receptor agonists, they're stabilized against DPP-4, so they don't need any DPP-4 inhibition to be fully active. Actually, there's only liraglutide left that is not completely protected against DPP-4. And there, in principle, you could see some interaction, but nobody has really cared to do that study to find out. But for short-acting GLP-1 receptor agonists, and there are two, of course. There is exenatide twice daily, and there is lixisenatide. There, it could actually make sense to combine them with a DPP-4 inhibitor, because then you would have the long-acting effect of the DPP-4 inhibitors, the 24-hour duration of action, combined with the short action of the short-acting GLP-1 receptor agonist, and that could actually be beneficial. But again, people have not bothered to do these studies in large numbers at all.
And I would say generally, since the predominant usage, at least certainly here, the predominant usage is with the longer acting agents, the likelihood is that there won't be
Yes.
A combination
Precisely.
of these agents. Now, it's different with the SGLT2 inhibitors. We've talked about the possibility of complementary mechanisms of action and even complementary benefits. In Jeffrey's case, this patient, there's actually a body of data, a number of studies that have been done which show that there are some beneficial results from combining GLP-1s and SGLT2 inhibitors. I want to move us to another quick discussion on another different kind of case. And I want to look at a patient, Wilma. She's a 61-year-old small business owner, busy, high stress again. She has type 2 diabetes for about 7 years. But she's had a long history of weight problems. She's been overweight, has had a difficult time controlling it. That is not something that is uncommon in our patients. Her A1C ranges from 7.7 to about 8.5. She's on a DPP-4 inhibitor and a low-dose sulfonylurea. She's reluctant to intensify therapy. She wants to keep things simple. She actually is one of those 15 to 20% of people who had intolerance to metformin. She had explosive diarrhea, so she just couldn't take it. She's heard encouraging things about these GLP-1s, especially about the potential for weight effects. And she now wants your advice because she's a little concerned about the GI effects that she's heard about, especially given the experience that she had with metformin. So what do you tell a patient like Wilma? Is this one where you would go forward with a GLP-1?
I would. I think that you are honest with her and you say that we don't know how you're going to respond. You may get some diarrhea from it. However, it's been my experience that people who do not tolerate metformin, that does not carry over to the GLP-1. And there's no reason to expect that she would. But again, if we go low, we go slow. We work with her, we see where her tolerance is. There is no reason why she wouldn't benefit from using a GLP-1.
And again, I completely agree.
Okay, and I think that it's important that a patient like her, you actually start with the acknowledgement that, listen, in the past, if we were going to take you to the next level of therapy with an injectable therapy, that would have been insulin. But now we have the advantage of offering you an alternative and then do the things that you talked about earlier, Davida, what the advantages are and how it might benefit her, especially given the concerns that she has about
Jim,
weight.
I'm sorry, I've also seen in clinical practice, and it came from clinical research, was, in clinical research, there are times when they say this is the dose the patient's going to be on. You can't up it, you can't lower it. And patients had a baseline of metformin, and they had terrible GI symptoms. We actually lowered or got rid of the metformin, and the GI symptoms went away. And these were in patients who didn't have any problem with metformin beforehand. So this is what I'm telling you, what I'm doing in my own clinical practice, is that sometimes when I add a GLP-1, the GI symptoms are the metformin, even if they've never had it before. And so we lower the metformin, and that seems to be helpful for those patients as well.
On another plane, when you talk to a patient like this and she's bought into the notion of a GLP-1 because of the encouraging things that she says, and she says, but I heard that there was an oral one, that you could take a tablet with this drug. What special educational challenges do you have to address for that kind of patient if you want to think seriously about using an oral GLP-1?
Well, I think Dr. Holtz outlined it earlier, but I think it's very straightforward. You have to take it on an empty stomach, nothing else in your stomach for 30 minutes, no more than 4 ounces of water, swallow it whole, all those good things. And what I tell our patients is that put it at the bedside. You don't want it to be with any other pills anyway. It's not like you're going to pop it out of its bubble pap and put it in with other medications. Put it at the bedside with a bottle of water. As soon as you roll over, before you put your feet on the ground, take that pill and take your water and then get on with your day. You know, it'll take most people at least 30 minutes by the time they get out of bed, get organized for their day, and don't have anything before that. The other caveat I always tell them is that, you know, you're starting with 3 milligrams, you go to 7, and for more control, we're going to take them up to 14. 7 plus 7 is 14. If it was another medication, we might say use up your 7 milligrams till you need a new prescription. We're not going to do that. We're going to use up all the 7s because you can't have 2 pills in that stomach, so we're only going to use the 7s or the 14 for the patient to get the benefit. And you know, we do this all the time with Synthroid, so there's no reason why we can't teach patients to effectively and correctly take this medication. So if she wants an oral, she gets an oral.
Yeah, I think that's well said.
Okay, we can also add that there's nothing dangerous in missing a pill or taking it, you know, too close to a meal. There's nothing dangerous in that at all. It's just that it's less effective if you don't follow the schedule.
Yeah, interestingly, I've had patients ask, well, you tell me I need to wait 30 minutes after I've taken it before I eat or drink anything. What if I go longer than 30 minutes? I said, no problem. In fact, that's all the better. It's just that less than 30 minutes is not so good. Okay. So let's talk quickly about the last case. And this is a 70-year-old lady, Evelyn. She's widowed. She lives alone. She has a history of coronary artery disease, so she has established underlying CVD. Her eGFR is stage 3, and she has obesity. She's significantly overweight, and she's been unable to tolerate sulfonylureas because of hypoglycemia, especially when she misses meals in the course of a busy day. Now, she wants to keep her treatment plans as simple as possible, and she's not keen on doing a lot of blood glucose monitoring because that she's heard unpleasant things about. But her overwhelming concern is about hypoglycemia, and her question to you is, you know, tell me what my best options are. So how are you gonna advise Evelyn?
Her DPP-4 inhibitor's not helping her at all.
No.
They may have been helping. Take them away and you'll see that they probably help a little bit.
No, I think that's a very good point. We don't know until we take it away what we're going to lose.
Exactly.
Absolutely.
But her A1C is 8.3. She's not at goal on the metformin and DPP-4. No. So she clearly needs more help. And I would think that given the concerns that she has about hypoglycemia, she's been on one of the modern NIAIDs, but it's not getting her there. She has a host of other issues now. She has underlying cardiovascular disease, she has obesity, and she doesn't want to do a lot of glucose monitoring. This is a patient that sounds like she's really right smack in the heart of what the ADA guidelines are saying about GLP-1s as a preferred therapy. Yeah. Patient with established cardiovascular disease, concerns about hypoglycemia. She's not at goal, and I think you can do some very good shared decision-making with her. Her kidney function doesn't rise to the point of being an issue with a GLP-1 choice. It seems to me that she is ready for that kind of discussion.
Absolutely. Absolutely.
So, do you use these agents often in patients with chronic kidney disease? How often? Because when we did survey results, 80% or more said sometimes to always. They do. So they are clearly hearing the message that these are agents, Jens, you pointed out earlier, that can be used across the range of renal function, which makes a whole lot of difference, even under circumstances when SGLT2 inhibitors may have some limitations.
Absolutely, and I think that message needs to be loud and clear that renal function is independent of the need or use of a GLP-1. So there's no reason not to use it at all levels.
What about liver function? Would the presence of hepatic impairment be a barrier to effective use of these agents? Because we see this not infrequently in patients with type 2 diabetes.
No, so it shouldn't be a problem. liver disease. On the contrary, to the extent that hepatic steatosis and NAFLD is behind some of the liver problems, it actually should be better. So there are some very encouraging results now in NASH and NAFLD with semaglutide that really suggest that it's helpful. It's helpful. So I really think that this shouldn't be a barrier. On the contrary, if it could be a help.
I agree.
And it may very well be that we've not looked at underlying liver disease, NASH or NAFLD, as sort of one of those under-the-radar accompaniments of type 2 diabetes that we would benefit patients by using agents that had some beneficial effect on those agents. Let's close with the top 5 takeaways from this presentation. Number 5. GLP-1s have favorable, proven effects on many of the pathophysiological deficits of type 2 diabetes, but the full range of their benefits is still being explored. Number 4, GLP-1s are highly effective glucose-lowering agents, yet they have an intrinsically low risk of hypoglycemia and weight gain. They actually promote weight reduction. Number 3, GLP-1s are not a replacement for insulin, but they are preferred over basal insulin as the first injectable agent for a number of compelling reasons. Number 2, GLP-1s may slow the progression of kidney disease in patients with type 2 diabetes in addition to their favorable cardiovascular effects. And number 1, some GLP-1s have achieved indications for cardiovascular risk reduction and have been shown to reduce the risk of death in patients with type 2 diabetes. I want to thank you for joining us. I hope that you, the audience, have been able to take away some important information on this wonderful, new, and exciting class of drugs for type 2 diabetes. And I am especially indebted to my 2 guests tonight. I want to thank very much Banting Award winner, Professor Jens Holtz, and my colleague, Davida Kruger, for this invigorating discussion. And I hope you, the audience, will have gained some important insights from this presentation. Thank you so very much, and we invite your questions from the audience. So we have a few questions that have come in during the course of the presentation, and we're going to start these in order, and we will be going back and forth to try to cover as many of these as we can. And the first question that we see is, can you start a combo basal insulin plus GLP-1, or must you start a GLP-1 then basal insulin if blood sugars remain high? Davida, you want to?
Sure. So, I think I'm going to start by talking about the standards of care, because that has changed. Both of us have been in diabetes for a gazillion years. And, after a sulfonylurea in the olden days, we jumped right to insulin. Well, the standards of care now say that after metformin, of course, we're going to do medical nutritional therapy, education, and those kinds of things, that you really should think of a GLP-1. And we're not going to start thinking about insulin until the A1C is probably 10% or 9% if the patient is symptomatic. So why do you want to do that? Well, there's a couple of reasons. GLP-1, if that's your next after metformin, you want to maximize that dose and see how much of the A1C lowering. If you look at some of the quartile data that we presented, you'll see that the higher the A1C, the better response you're going to get in terms of lowering. And so that you want to maximize that. Why? Because you're going to get a cardiovascular benefit. You're going to get weight reduction instead of weight gain, and it doesn't cause hypoglycemia. Now, after you've done that, and remember that a GLP-1 also controls fasting blood sugar and postprandial. If I were to choose just basal insulin, it's probably only going to control just fasting blood sugar. So give the patient a GLP-1, maximize the GLP-1, always go low, go slow so that you don't have side effects. And then if you think you're going to need another medication, you can consider adding a basal insulin at that point. But there's no jump to doing combo therapy from the get-go. Really maximize the GLP-1 and all of its benefits.
Very good. There's an additional question. Is there any GLP-1 receptor agonist which can prevent diabetes-induced neuropathy, or if they can treat diabetes-induced neuropathy? I think there may be some conceptual issues that need to be addressed here based on this question.
Sure.
First and foremost, remember that diabetes-induced neuropathy is one of the well-established microvascular complications of this disease, whether type 1 or type 2 diabetes. So what you're talking about here is a legacy of poorly controlled or uncontrolled hyperglycemia. So the GLP-1s don't specifically prevent diabetes-induced neuropathy. What you have to think in terms of is that this is one of the tools that is important for controlling hyperglycemia.
Yeah.
And when you control hyperglycemia well and get people to target, keep them at target over the long term, you can, under those circumstances, prevent diabetes-induced neuropathy. So it's probably best not to think about the GLP-1s sort of in a basket of agents that can prevent diabetes-induced neuropathy. That's not what they do, but they definitely are very important tools, as you've heard in the presentation, for achieving better overall diabetes control. And one of the legacies of that would be to prevent complications like neuropathy. Was that a fair statement?
Yeah, no, I agree with you. I think that we need to step back and say you control the diabetes, you control the complications. But if a patient has neuropathy, that's not the drug that's going to prevent it per se directly from progressing. It's the controlling of the diabetes that hopefully prevents the progression of the diabetes. I agree with you 100%. So there's another question here, Jim, that I'd like to get at about whether you would put a SGLT2 inhibitor first, or you would put a GLP-1 receptor agonist first. And that's where we really think about individualized care. And so again, going back to the standards of care, they're really clear about looking at the patient's cardiovascular risk or renal complications. So if your patient is on the side where their greatest is they have cardiovascular complications or cardiovascular risk, then after metformin, you'd probably reach for the GLP-1. If they already had renal issues, then you'd probably reach for the SGLT2 inhibitor. Now, there's nothing that says you can't have both drugs. So if I go metformin, I maximize the GLP-1 receptor agonist, and then there's benefit to bringing on the SGLT2 inhibitor, or the other way around. But there's a little algorithm that says look for the cardiovascular risk, look for the renal risk, based on whatever that is. That's what you're going to pull for that patient. It's a new way of thinking of diabetes, because we finally have medications that can prevent or slow down the progression of cardiovascular disease and can help with renal function. And we just have to keep that clear.
And the only other thing I would add to that, Davida, is that remember that there have been a lot of head-to-head trials. And
Yep.
when you're individualizing therapy, remember what's important to the patient beyond glycemic control, even beyond cardiovascular protection. If weight reduction, for example, is an important priority, remember that all of the head-to-head trials show that for equivalent amounts or for similar amounts of cardio protection, the GLP-1s give you quite a more robust weight reduction. So that may be one of the things that you factor in. The shared decision-making is one of those important things here.
Absolutely, absolutely.
Let's address the relative efficacy of oral versus injectable GLP-1 receptor agonists, because we only, I'll just start with that, because we only have one head-to-head data point or study that's been reported, and that was oral semaglutide compared to injectable liraglutide. And under those circumstances, the A1C reduction was essentially non-inferior. It was about the same, although a slight edge to the oral GLP-1. But the weight reduction that was seen with the oral was actually more robust than the injectable liraglutide. So the fact of the matter is that you don't suffer any downside at all by using the oral formulation based on the data that's available. But that's only been done in head-to-head fashion with one of these. You have any?
Yeah, and I think that yes, you're correct on the head-to-head, but I also think if you look at the research that's been done with the oral in of itself, and they did do it against a lot of other diabetes medication, that the efficacy of the oral GLP-1 shines. It's got a great A1C reduction. It has weight loss reduction. Its side effects, its GI side effects are no greater than the injectable. And it is not, as I shared during the presentation prior to this, it's not that difficult for a patient to take it correctly. So, I think, again, it's a matter of patient choice. Do you want to take a daily oral? Or might you want to do a once weekly injectable? So I think that, the efficacy is there for both.
Yeah, and if a bottom line of this development or the availability of this particular formulation is, if you're reaching for another pill for intensification purposes to better manage diabetes, now you have an option of a GLP-1 in a pill, as opposed to something that you might have reached for in the past in the incretin family that would be decidedly less beneficial to the patient overall.
I think that's a really good point.
Is there a specific A1C level that you should not use a GLP-1 after metformin? Example that the questioner says, I was told that with an A1C of 10%, I should start insulin. Very interesting.
So, the standards of care say that if your A1C is greater than 10% and symptomatic, yet yes, go ahead and start a basal insulin. Now, if you do start a basal insulin, that doesn't mean you can't add a GLP-1 onto it. So let's say the A1C is 10%, you add a basal insulin, now it comes down 2%, but you still need postprandial control. Instead of reaching for mealtime insulin, put on a GLP-1 there, and you're going to get more basal and you're going to get postprandial control. And very often, as the A1C comes down, you add the GLP-1, you can lower that insulin. So get the patient under control, see if you can't cut some of that insulin, if not all of that insulin. But if you need more control after the basal insulin, and for many people you will, think about a GLP-1 to get you your postprandial control and get that patient to goal.
And you used a term that I think is very important to highlight, that if the patient has a high A1C and symptomatic, then you definitely are going to be leaning towards some insulin utilization.
Can I also say, sorry, Jim, I also want to say is to be sure you have a patient that has type 2 diabetes,
right?
Because we see that all the time. We're making the assumption the patient's overweight, that they're older, and that they must have type 2 diabetes. But if they have absolutely no family history of type 2 diabetes and they've lost an enormous amount of weight, you may want to think about, and there's a ton of other ways that you might need to look at, but think about type 1 as well. And certainly if the A1C is greater than 10%, you think you might have type 1 diabetes, give that patient insulin.
Yeah, excellent point. And I would point out, on the issue of patients who have high baseline A1Cs who are not symptomatic, there are numerous studies that have been done on such patients who have responded extremely well in sort of, post hoc analyses with excellent A1C reduction, excellent weight reduction, and so forth. So don't rule those patients out with respect to the benefits that come from GLP-1 utilization.
Absolutely.
In them. I think we've run out of time. Uh,
We
well,
could go on
let
forever.
let me thank all of you for the questions that you submitted, and let me thank my colleague, Davida Kruger, for the presentation and for the information. And we really do hope that this has provided you some insights that will be helpful to you as you think about how to use this marvelous new category of therapy that offers so many benefits for patients now with type 2 diabetes. So thank you very much for your participation, and all the best.
Thank you.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education.